Okay, so we're going to move on to our panel now, and we'll bring up the folks in the panel, I suspect, here. This is the cases, and these really are cases that I'm getting from clinicians. I literally ask them, what are the issues that you're dealing with the most, and try to consolidate them. Those of you who have seen this talk before, there's variations on the theme. Some of the questions are similar, but the answers sometimes change. So I thought it would be important to go through that with you.
And I think the music will be different this time, right?
It'll be very different. So our panelists here are Dr. Lennox, who you've just heard from, Dr. Carlos Del Rio, who is the director of Grady Health, if I'm not mistaken.
No, whatever. Don't worry about it. I'm not the director, but that's okay.
At Emory University and longstanding HIV provider, and Paul Volberding, who we saw earlier and has been at this since 1981, founded the first ever outpatient HIV clinic in the world at Ward 86 in San Francisco General Hospital. So we'll go ahead and get started. These are my disclosures. We're going to talk about initial therapy, elite controllers, TDF versus TAF, pregnancy that we just sort of got some questions about. What do you do with people with low level of viremia if you have an M184V at baseline and our slow CD4 count response? So let's just dig in. And I'd like to frame this based on the question that sort of came to me from the clinician. I modified a little bit to make it more digestible. But here's the question. Seems like we are now starting ARV therapy for just about everyone. What about starting immediately at the time of diagnosis? So here's a case. 30-year-old man was diagnosed with HIV 4 hours ago in the emergency department. Asymptomatic, don't have any data. None of these data are available. The other labs, the white count is 3,800, lymphocyte count is 20%. Doesn't have any significant prior medical history. And then if you tell him, hey, you should start now, he or she, or he will, And so let's go ahead and go to the question. Would you choose to start therapy right now in the ER within 1 to 2 days? Let's bring up the question. I think you get it. Let's poll, and we'll give you a chance to vote. I'm wondering if I'll mess up my screen. I was going to try to bring up my own personal music. I can do it off my iPhone. Yes. Let's figure that out. Okay, let's see what we got. And it looks like the majority of people go into. So Carlos, you guys at Emory, you did a study like this a couple of years ago. What's your opinion? How would you vote on this?
Well, it wasn't a study exactly like this. It was about, doing rapid starts. I am a little nervous about starting somebody in the ER like this. I want to be sure that we can connect them to the clinic. And I don't see the urgency to start the individual immediately in the emergency room. I worry that the continuity, I just find the ER to be too disruptive. I would make sure we can get him at a place that I can have a better conversation than what you do in the ER. And I said within 1 or 2 days is fine. I would like to do it, as soon as possible. Now, if the individual says, I truly want to start, I'll go with the patient. But my preference will be, 1 to 2 days. Once I can get him linked to care, I can ensure that the person, we're going to have, unfortunately in our country, ensuring that you get ongoing medications require certain things you need to do. And it's not that simple. And I worry that I give him a start pack and then we ran out of drugs. So I want to get, at least be able to draw viral load, a couple other things. I don't need the result, but I want to have those things before I start the person.
Yeah, Paul, what are you doing out in San Francisco?
So San Francisco is sort of a hot spot for rapid starting, and the clinicians here really feel that it has helped bring people into care effectively. What we would do would be to send the person really to the clinic, not start literally in the ER, but they at San Francisco General they have a really well-oiled machine that allows them to get started the same day. I don't think it's magic. I think starting 1 or 2 days later should be fine. But I think the message that everyone is getting is that everyone should be treated. everyone should be treated quickly. We should really work on the systems to allow that. So, yeah.
Well, I don't know that it's really biologic, right? They've been going on for probably a year or two or longer, maybe, with the infection. So a day or two isn't going to matter. But I think from a social standpoint, from a psychological standpoint, getting something done implies to the patient that this is important, and we're not going to let this kind of just ride. We're going to move on this and help you get into treatment as soon as we can. And right now in the ER, gosh, at least at our place, we're so overwhelmed with COVID right now. They want us out as fast as possible. So it's even going to work. All right, so let's talk about for this patient. Let's say they come fast-tracked, as we call it, to our clinic. What are you going to use? Let's look that over. There's all kinds of options here. Let's bring up the poll, and I'll try to play some music while we do this. Let's see how this works.
The Scotsman dropped in the middle of a forgotten spot in the Caribbean. My Providence impoverished and squalor. Grow up to be a hero and a scholar. All right, let's see what Hamilton answers here. Okay, the majority of people went fixed dose combination. Jeff, what do you think?
I mean, obviously that combination has the benefit of being one pill, and it has, broad activity and potentially against any NNRTI resistance virus that's been transmitted. So I don't think that's bad. I think some of these other combinations, like the TAF FTC plus dolutegravir, would have the exact same benefits, but just would be 2 pills. And some of the other combinations you put up would work over the short term, even if you had transmitted NRTI resistance. So,
what are some regimens you wouldn't use? It just wouldn't be the right idea at this point.
Well, the low dose efavirenz, obviously that has the potential to have less side effects. But if you had transmitted NRTI resistance and it took you a few weeks to get your resistance testing back, that might be enough time for 3TC resistance to develop. And potentially you could make the same argument if we had more transmitted integrase resistance with raltegravir or elbaptegravir-based regimens. But currently, as far as we know, there's still not a lot of transmitted integrase resistance.
And abacavir is wrong unless you have your B5701,
Right.
I've heard some people talking about, well, we could try the dolutegravir 3TC up front and then adjust if we find that there's an M184V or if the viral load is over 500,000. What do you all think about that?
I think it's a bad idea.
Yeah, it's probably better to wait. And then you could always transition over if you wanted to later.
You don't have a viral load. You don't have a CD4 count. You don't have a genotype. You're basically shooting yourself in the foot by doing that when all you need to do is add one more drug, right?
Right. And so I think running through the rest of the list here, most of them are okay. The rilpivirine, for the reason we talked about earlier, probably not the right choice. The darunavir can work, but then you're giving more pills and you're introducing a boosting agent. And the same thing about boosting with elbaptegravir. We'll get to that a little later. So let's say now, just for any patient, now you have data back. Let's say they're coming back at 7 days. What we do a lot of times is we have folks come in, we get them oriented, get some lab work, and then have them come back for a provider visit a few days later. It's variable, but let's look at this story. So you got a 48-year-old guy. You have some data now. HIV RNA is 28,000, CD4 count 650. The labs are over. The virus comes back wild type. No prior medical history to speak of, normal renal function, and okay to start therapy. So let's go ahead and vote on these regimens. Pull up the poll, and I will try to play some music.
I may not live to see our glory. I may not live to see our glory. But I will gladly join the fight. But I will gladly join their fight. And when our children tell our story. And when our children tell our story. They'll tell the story of tonight. Let's have another round tonight. Let's have another round tonight. Let's have another round tonight. Raise a glass to freedom.
I can't stop this.
Something they can never take
Sorry.
away.
That's the part I didn't Well, all
So
right.
Mike is serving as the DJ.
I know. This is not good. All right. So most people went with the same regimen. It's interesting. Did any of your thoughts change?
I mean, I would have been fine with dolutegravir 3TC in this patient.
Yeah, this is an ideal case.
This is the one patient I would have been fine with dolutegravir 3TC. Again,
Yep.
I have nothing against bictegravir TAF FTC, but it's if you want two drugs, if you want to avoid the TAF, if you want to avoid it's a woman or a young person, you want to avoid the weight gain. I think the dolutegravir 3TC option is a good one.
What about other ones? Was this one that you could use rilpivirine if you wanted to?
Yep, because of the low viral load and a high CD4 count.
Right. So I think almost any one of these options, and we're assuming the B5701 is negative, but we're really probably not using a whole bunch of abacavir these days, especially with the option number 6 here. So here's a question. You've been primed already from Dr. Lennox. In terms of TAF versus TDF, or would you say either? Let's go ahead and vote on that. And I'll try to get some music without not being able to stop it.
Folks love more than going downtown and slumming it with the poor. They pull up in their carriages and gawk at the students in the college just to watch them talk. Take Phillips.
All right. So most people, about half, are still going with TAF, and then a smattering of others. Jeff, you presented this. Have those data changed your opinion at all?
No, they really haven't. I mean, obviously, the fixed dose combinations with TAF are very convenient, but I've been telling my patients for years, the newly diagnosed ones, that they're going to gain a lot of weight, and despite lots of warnings and counseling, et cetera, people are putting on weight. So I am tending to try and think about TDF a little bit more for treatment naive people. Again, obviously it has its drawbacks.
Carlos or Paul, any comments?
No, I agree. I think I do think it's kind of settling in that, as Jeff pointed out, that there probably really is some weight gain associated with TAF. But it's a trade-off.
There's no perfect drug, and I think if you have somebody who has renal disease, cardiovascular disease, diabetes, a smoker, TAF is probably better than TDF. But if you have a young person with none of those things who is very interested in not gaining weight, maybe TDF is better, or maybe again you avoid both of them and you use two drugs when you can.
Yeah.
So this
I was a little, again, going back to the previous case, I was a little, worried by the data presented about not having enough reduction of inflammation with two drugs. Maybe you want to comment a little more on that?
being less inflammation.
Yeah, but less control of inflammatory response from the IAS data that Jeff presented.
I mean, the question is, what's the meaning of that over time? And
Correct.
I don't know what the answer is to that, to be honest.
Right. I mean, you need much longer follow-up on a larger cohort of patients.
These are data on TAF versus TDF with dolutegravir as a base, and you can see at least with the red and the blue lines, they parallel each other pretty well. The efavirenz is a little bit late to the party, but ultimately gets there by week 24. One of the things that was a little bit in the journal Viral Eradication, which most people maybe don't see, but this is Andrew Hill, who's been involved in drug development really for 25, 30 years in HIV. And what he did is he did a meta-analysis. I think the take-home point here is that most of the TDF bad events, be it renal or bone, are really in the setting of a boosted regimen. And if you look at the compilation of at least data from clinical trials, there's not much of an effect that you can see of one versus the other. And and especially in the unboosted setting, and see how narrow those confidence intervals are right at the zero from not favoring one or the other. And the same thing was really true in bone toxicity as well. Now, if you're doing DEXA scans and you're really, really looking at this at a detailed level, you obviously are going to see the differences in bone. The question, I think, for all of us is that in these types of studies, on the one hand, these are pre-selected people who are pretty healthy, and on one hand, so that you could say, well, maybe for somebody who's a little older, this might not apply, and probably doesn't to the same degree. And that also gets back to the point of DEXA scans, which really were developed where an older population was so normalized about that. When you start looking at DEXAs in 25 and 30-year-olds, it's hard to know exactly what the data mean, because it's just not the type of thing that we see in young people as a rule.
My only issue, Mike, is, and I agree with you, my only issue is that given where we are in HIV, people are going to be in these regimens for the rest of your life, right? For the rest of their life, unless we find a cure. So you're talking about, putting a 20-year-old with a drug until they die that has potentially a problem with bone toxicity. So we may not see an issue today, but what happens 50 years from now when that 20-year-old is 70 years old?
That's exactly right. And I think I'm just trying to create some degree of balance here in the sense of, when TAF got released, everybody flocked to it because of these types of data. Now we're seeing the weight issue, and we're having to try to balance. And to me, the whole point of bringing all of this up, especially in the context of what Jeff presented just a little bit ago, is that as we get more experience with any drug, they lose their shine a little bit. And right now we're in, I think, kind of a toss-up. And until we get more data, it's going to, we'll retrospectively look back and say, should have been doing this. But I think everyone has a pretty good sense. The good news to me, and I think to all of us, is that we have great choices. And I don't, really, dancing on the head of a pin sometimes with some of the nuances.
And then, Michael, one of the reasons, obviously, for the interest in this islatravir is that it's another drug in the same general class as an NRTI, but it may not have the same toxicities. So
that's right.
Time will tell.
And then the capsid inhibitor is a whole different mechanism that we didn't go into great detail on, but that's a drug that it has two places where it actually inhibits viral replication. One is on the entry into the nucleus where the capsid acts, and then it also interferes as the viral particles coming out. So you're almost getting two simultaneous effects with one drug, and we're going to be watching that very carefully. And I believe the new name for that drug is lenacapavir. So our eye out on that. So we've already answered this question, so I'll go through this kind of quickly so we can get to some others. But this is a woman who started on Big TAF FTC 12 months ago. She switched over from a darunavir-based TDF regimen, and now, her viral load stays suppressed as we expect. But her weight increased about 26 pounds. And so at this point, what would you do? You have data now that you've seen.
Can you go back to the case?
Yeah.
Okay. Go forward.
All right. So are you going to keep her on her current regimen or switch to one of these other choices, including putting her back on what she was on before? Let's go ahead and vote.
Is there none of the above?
Some other option.
Some other option, yeah.
Oh, didn't give you any music. Well, all right, we're probably too late for this one. Okay, let's see what we got. So the majority of people are kind of pulling a George Herbert Walker Bush, not going to change, wouldn't be prudent. Some of them went with the Carlos Del Rio, 34% of some other options. So, Carlos, what would you say?
Again, this would be a good person for dolutegravir 3TC. You drop off the TAP and hope that, some of the weight gain is going to be from the dolutegravir, but some of it may be from the TAP, and I want to see what she does without TAP before I give up on the dolutegravir.
And you could also try the dolutegravir rilpivirine route.
That's the other option.
Another two-drug regimen.
Correct.
I guess
but you would do so without much optimism that you're going to see an immediate weight change, right?
Right. And
correct.
That's the word. And that mechanism is really quite obscure right now, isn't it? And I want to sort of show some data on that. So the question came in earlier from the audience about, well, is it relative not only to PIs and NRTIs? So the left-hand panel A shows you that, as a rule, the integrase inhibitors have a little bit more weight gain, and these are coming from combined clinical studies. And on the right is answering that question a little bit about which of the integrase inhibitors is most associated with this. And unfortunately, this analysis did not include bictegravir, so I can't comment directly on that. The hint is that dolutegravir and bictegravir track more together than, say, than the raltegravir, but don't know that 100%. But what I found interesting is that if you just sort of look at the first year and block that out, and now look at it, it gets back to a little bit of the point that some of the audience members were raising earlier, is that, does it continue on or does it plateau? And it levels off a bit, but the weight gain does continue, although albeit with a much less steep slope. So when you all see this, Jeff, I'll turn to you. How do you view these data?
Again, before we had all these switch studies, it made me more inclined to potentially use an NNRTI up front if we had one with less toxicity, et cetera, like rilpivirine. But a lot of the patients we are seeing that have gained the weight, they're now 2 years into treatment. And so I'm not sure whether switching is going to do anything. And obviously it's got to be an individual decision. And if so, what do you switch to is obviously the hard part.
And when
that's the really hard part, right?
Yeah.
And sometimes it goes against the principle of not mucking with success.
Yeah, that's true. An interesting, Jeff, again, coming back to you, the data on doravirine and NNRTI with islatravir, that new drug, as a combo. What do you think of that? And this, we need the data for weight gain.
I mean, it looks like it's a good antiviral combo. The question is, what happens to people's weight, right? So you need a much bigger study followed for at least a year or two.
Yeah. So as they said in Jaws, we're going to need a bigger boat.
Yeah.
Okay. So what regimen should I use as an initial therapy in a pregnant patient? And we got to this a little bit in Jeff's presentation, but let's take it into the real world. So this is a 30-year-old female who's newly diagnosed. She's asymptomatic, and she was diagnosed as her prenatal visit, and she's 2.5 months pregnant. And she's got a viral load of 28,000 and CD4 count of 650, very similar to our last case. She's B57 negative, wild-type virus, no prior medical history to speak of. It's her first pregnancy, and she's okay to start therapy. So I'll give you a few seconds to digest this, and we'll go ahead and pull up the poll, and we'll go ahead and vote. Okay. So dolutegravir, that would not have been the answer a year and a half ago, would it?
No, would have been very different.
So comment, anyone?
Well, a big choice is between the integrase and the efavirenz. I think that question has been pretty well answered. I think the integrase works better. And I think that as we saw the data, the fact that neural tube defects really don't seem to be a problem. Here, she's almost out of her first trimester, so I think it would probably be safe to use dolutegravir.
Yeah. Are there any wrong options here that you see? I'll take that one myself.
Yeah.
The cobicistat has.
Cobicistat is not a good idea.
Yeah.
That's a take-home point, that you don't want to use a regimen with Cobi. So you could use darunavir boosted with ritonavir. That's fine. We've done that for years. Same thing for atazanavir. And now we're finding that TAF actually is okay. So you could use TDF or TAF. A year ago, I was saying, hold off on TAF. We don't really know yet. But I think there's now enough data. There's actually a randomized trial that showed that it was relatively safe. And so I think we can throw that back into the mix.
Yeah, we have a lot more options compared to a year ago now with those.
Absolutely.
Yeah, again, the combination of what Jeff presented and Sempano on most recent analysis, and you have the analysis here in Croy, but the most recent analysis just presented, and the data presented also by, the sort of the cost-benefit analysis by Rochelle Walensky published in the Annals, I think have made us a lot more comfortable with dolutegravir. It's still not zero. It's still not zero risk.
Right. So tell us about that cost-benefit analysis. It basically showed that it was.
You get more suppression and you get less maternal mortality.
Right.
Maternal mortality with dolutegravir. So there's clearly a cost-benefit advantage
Over the efavirenz.
Over the efavirenz-based regimen.
Right, and these are data along those lines where you can see that the time to decline of viral load was faster. We knew that. That wasn't new. There was actually one abstract at the IAS meeting last week that showed that that speed didn't translate into less transmission. In other words, that both were relatively the same effectiveness in terms of not transmitting to the infant. However, most of those situations, as we know, is when there has been intermittent adherence. I think it's rare. I'm not sure I've ever heard of a case where somebody is fully adherent and viral load is suppressed where we're getting a transmission. There may be an exception or two, but that's generally the rule of thumb. And so, as we've talked about already, dolutegravir is now a preferred integrase inhibitor for ART-naive women. I will make a couple of quick caveats here. One, this is exactly the same story that we saw 15 years ago with the efavirenz, maybe a little longer, where we started seeing neural tube defects in women on efavirenz when it was being used. And then as more data came in over the year, that signal started to disappear, just like dolutegravir, same exact story. And the second thing I'd like to bring up is that folate seems to be really important in neural tube health for infants. And so what we don't know either in the efavirenz story or in this one is, relatively speaking, what the folate levels were among the women who received this. And I think there's been some data that biologically showed that dolutegravir in particular does interfere with folate delivery to cells. So if somebody starts off at a lower folate level, that's where you might start seeing the impact. So take-home point, give folate to women, especially if they're considering pregnancy or if they become pregnant. That is always a good thing to do. Let's change gears a little bit and go to elite controllers. We have, it's about 1% or less. A lot of experience in San Francisco at Paul's CFAR. 30-year-old man, male diagnosed with HIV 7 years ago. He's always been asymptomatic. His baseline RNA is less than 50, and it's been that way the whole time. The genotype from a DNA was wild type, and he's okay to start therapy. Would you start therapy on this guy? His CD4 count has been stable at anywhere between 800 and 1,000. He's now at 850. Let's go ahead and vote. Well, I'm not sure today's a great day to look around with COVID, but anyway, so this is interesting because this answer has changed in the 10 years.
But it's moving in the right direction without any clinical trial data.
Well, yeah, so how are we going to get clinical trial data when it's less than 1%, right? And then we tried, but we failed. Yeah. I know. So, Carlos, take it. How would you answer this?
I tend to believe that there is some benefit of therapy in in inflammation and organ disease and other components that were not necessarily just the virus. And I think that clearly there's enough evidence to suggest that you have some impact on T cell activation that you're showing. I mean, that's Peter Hunt and others have shown this. So I have a discussion with the individual, but I would be in favor of starting them on therapy rather than waiting. Now you have to truly be sure that it's a true elite controllers. There's some people that are called elite controllers when their T cells over time are starting to come down. And I think you also need to be careful that those are not, in my mind, truly elite controllers. So I tend to be a one that wants to treat or suggests that I'm in favor of treatment. I see very few reasons why you wouldn't treat somebody. But again, it's really at the end of the day up to the patient, right? If the patient says, no, I don't want to take any medications, then you have to, say, okay, here's the evidence and see you soon.
And just remember that all drugs have side effects. They may be subtle, but I tend to agree with Carlos. I'm under the influence of Peter Hunt, so I would probably lean to treat. On the other hand, it certainly shouldn't be a strong recommendation.
Right. I think the take-home point that we're hinting around here is that yes, these individuals have a remarkable ability to suppress viral replication to the degree that you can't detect virus. But that activity, that effort, if you will, to keep the virus suppressed is challenging. And over time, like years, the question is how much will that take a hit on their ability to stay healthy, especially when it comes to issues related to cardiovascular health and that type of thing. And if you're giving them a little bit of help with the antiretroviral therapy, especially if you use a relatively minimal intervention without much toxicity, I think it's people can lean towards that. One other good take-home point is that learned this from Peter and Steve Deeks is that in general, if the CD4, one thing to look at is a CD4-CD8 ratio. And if we find that CD8 ratio is low, like less than 0.5, that's someone, even though their viral load's under control, that's someone who's going to have more chance of at least progressing back to detectable viremia. And that's someone you might segregate out as being treated early.
So, Michael, I'm going to pose a question to you. Since the viral load is so incredibly low, is this somebody that you would consider 2 or even 1 drug treatment for?
Yeah, I mean, I thought about that, and you could say, well, one of the protease inhibitors by itself probably would work. I just worry a little bit, what's dogma one day is dog manure the next. I mean, we were all into 3 drug regimens until we saw data for 2. It could be, but again, to Carlos's point, how do we study this, and do we take that chance? Maybe something like a capsid inhibitor that has 2 mechanisms of action is pretty potent. That might be a choice.
I would argue, Mike, that then you're combining 2 unknowns. We're not really sure whether treatment should begin at all, and then we're kind of playing around with the drugs, using it. Yeah.
So to answer your question, Jeff, I mean, no, but I might use a 2-drug regimen, one of the ones coming out. So how about this? We see these folks, patients who have persistently detectable viremia. So this is a story of a 55-year-old guy who was diagnosed 18 years ago and had pretty advanced disease at the time. And now he's been on successful therapy. He's been through the regimen you see listed there at the bottom of the screen. So it sounds very familiar to those of us who have been at this for a while. But now he's really happy, stabilized on dolutegravir, boosted darunavir, and 3TC. And when he comes to us, he doesn't have any resistance, but yet he's at 85 and his values are hovering somewhere above 50 and less than 100. So would you change therapy on this guy right now? Yes, no, not sure.
Tag volunteer army in need of a shower. Somehow defeat a global superpower. How do we emerge victorious from the quagmire? Leave the battlefield waving Betsy Ross's flag higher. Yo, turns out we have a secret weapon in immigration.
All right.
So if you combine yes and maybe, it's almost 40%.
Yeah. So what do you think, Jeff?
I think the data so far shows that there is no benefit to changing the antiretroviral, and that continuing people on their existing regimen doesn't lead to the development of resistance. I'd be interested to see what Paul or Carlos thinks.
Oh, I think we're all just nervous, but but whatever you do, you're going to be nervous probably. So
yeah, I would work on this guy, talk about adherence, have a good conversation about the importance of really good adherence, and then follow the person closely. I don't think he is at risk of failure. I don't think he's at risk of having a developing resistance. But I worry about the persistent low positivity over time. Those people tend to not do well.
I don't think there's much. I don't know all the data, but I don't think there's much issue with adherence in these people, is it? I think it's really something more inherent, and probably they started out with a very high viral load.
Right. That's the point I want to make. So I think it's important to go back to the biology. So this is what we want to see, except in this case, it's above 50. So you kind of go, now what do I do? And a blip we know doesn't have much impact, but this isn't a blip. This is where let's call the treatment set point is somewhere above 50. And so I think it's really important to go back to the biology. And if we remember, the way that we detect viral load is in the plasma, and it's coming from HIV-infected cells in the body in the top part. And then the antiretroviral therapy that you see there on the right-hand side, that blocks the ability of the virus to infect activated CD4 lymphocytes. And all intents and purposes, antiretroviral therapy in today's world blocks this 100%. There's very little evidence for ongoing de novo replication. And without the de novo replication, then it becomes really almost impossible for resistance to emerge. And that's point one, that in these people who have been followed over time, you would expect that if there was ongoing replication, that ultimately just stochastically, just by chance, there would be emergence of resistance. We don't see that. A second point, we've done studies and others have done this. In fact, Deeks and Hunt did this a while ago, where you add a fourth or even fifth agent to this to see if you can drive it down, and you don't.
You don't.
Right where it is, right? So that what that is, if you go back to the top part here, the HIV-infected cells, those die off over a period of about a day or two. But on the upper right-hand side, you see the latently infected CD4 lymphocytes, and those cells are the reservoir, if you will. And every now and then they spit out virus that you can detect. And the point is that reservoir is usually bigger in somebody who had very high baseline viral load like this guy did. And so I think what we're looking at here is mostly biology, and that these folks, we can't change this unless we find a way to reduce the latent reservoir population. Now, this is the concerning part, and Carlos alluded to this. These are data that just came out of CROI just in March. And what you're looking at here is that those people who had persistent viral loads between 50 and 999, and then they break it down further between 50 and 199, you can see just below the line there, they do better than those people at the bottom who have high level viremia, but they don't do as well as the people who are less than 50. My take-home interpretation of this is that it's not because of ongoing replication, but there is something as a marker. Someone who at baseline had very high viral load, you get it under control, they do well overall, especially obviously to no treatment, but they don't do quite as well as the people who, for whatever reason, can get it under control. What can you do about that? Not much. I mean, this is the biology. This is that person. So we do all the best things we can to kind of keep people functioning and doing well. I just think this is biology, and we so far haven't been successful at changing that.
And I think it's worth mentioning also that there's no point on changing, but there's also no point on adding drugs.
Right. That's right. I mean, if you want to experiment, you can, but it's unlikely to change anything.
Another point, Mike, just to reinforce what you just said already, is that everyone is viremic. If you use a sensitive enough assay, you're going to find occasional virus particles. And what we had in our clinic noticed is that suddenly we were seeing more of these persistent, very low-level viremias. And it turned out that because of COVID, we had switched the lab that we were using for our viral loads and to one that had a higher or a more sensitive assay. And so we were just not seeing them before. So there's a lot going on here.
Well, that's a great point. And I think now that we've been having viral load for many, many, many years, we've sort of gotten away from thinking about the test itself. And when we were struggling with this in the mid-90s about, well, does viral load tell us anything? And the answer was, it does. But the point is we saw that threshold go from, 10,000 cut off to 1,000 to 200 and now 50 and 20. You're right. I think what we maybe can take away from this is that perhaps that, let's call it on treatment set point, if you will, that level is really more of a reflection of their reservoir, perhaps, than it is of any kind of ongoing replication. So this is, by the way, this is obviously retroviral failure. So even in people that have got persistent low-level viremia, when it starts going up, it usually takes off. And it's not just a blip. It continues on higher. So how do we manage these folks? I'm not going to really give a case here, but I wanted to get back in the last couple of minutes to some of the newer therapies. Jeff alluded to fostemsavir that's just been released. One thing I'll start with is that the CNIX group with Mari Kitahara did a really nice analysis. And what they're looking at here is people with limited treatment options, or you could call them highly treatment experienced. If you go back over time, if you look at the proportion of the population who had that place where they didn't have much we could do for them, that number went to like a peak of 8%. And then notice that around 2007 it drops. Why? Because integrase inhibitors came around. And those of us who lived through the days of 2000 to 2002, we were using things like T20. It helped us. It was a new drug, but it wasn't sufficient. But the integrase inhibitors were game changers. And so it added a new option that we were able to do. But I think what's interesting about this analysis is that if you look out over time, that amount of people that we're experiencing who we're having trouble concocting a regimen for is vanishingly small. It's not, certainly they exist, right? But they're the types of patients who nowadays with integrase inhibitors, if people are taking their medicine, we can usually bring them under control. So what it's telling me, at least, is that a lot of the folks who are in this category now are folks who have trouble taking medicines or have had other things in their life that are interfering with that. What was fascinating, though, is that if you look at those people, especially recently, once the integrase inhibitors came around, and the success once the integrase inhibitors came on board of getting undetectable tests was no different after 2009 between those who had limited treatment options and those who didn't. So though integrase inhibition was a game changer. So what do we have? Just a general rules of thumb: confirm the virologic failure, explore the prior regimens and the resistance tests, as we always do, and then, of course, try to find two fully active drugs. Sometimes it's dolutegravir twice a day. Sometimes it's tenofovir, but the K65R could hold us back there. Boosted darunavir seems to help a lot. And then we have these new drugs, ibalizumab and fostemsavir, that we can throw into the mix. And just to finish that out, and I want to hear from you guys after so we didn't have time to go into this earlier, so I added a couple slides here. But the key thing about this drug is that it binds to GP120 and prevents the binding to CD4 cells. The PK is done daily. One thing I think it's important to note is that there's some changes in the GP120 that make it difficult for the parent drug temsavir to bind. Yet in the studies, it didn't seem to really matter that much. Just quickly to go through that, the end of the day effectiveness, or getting less than 200 copies, was just as good, depending on, at least at the end of the study period, regardless of that. So no one's recommending at this point to test for that prior to administering this drug. So that's a whole bunch at once. Comments from the panel.
I think in the BRIGHT study, in the subgroup that had very few active drugs, that you saw that the fostemsavir had a degree of activity of about 0.7 log reduction, which is very similar to what we used to see with zidovudine and
Right.
stavudine, et cetera. So it definitely has antiviral activity, and it seems to be well tolerated. Cost is potentially going to be an issue. You know, if you have somebody on ibalizumab and fostemsavir, just those two drugs alone, if you were paying full price for them, would be about $200,000 a year.
Yeah. And I think, you pull back to the big picture and say, well, why are they charging so much? It's because not that many people.
Very small population.
So, yeah. So they've got to charge, I guess, that much to make back.
Oh, it's because they can.
That too. Okay. And
anyway, guys, thank you.
As Jeff announced, this was approved this month. So the conclusions: ART therapy should be initiated with an integrase inhibitor unless otherwise indicated, as close to the time of diagnosis as we can. In the presence of low-level viremia, probably best to just continue on with what you've got. And as we said, also adding new drugs to that doesn't necessarily improve things. When I didn't get to the low CD4 count response, but the take-home point there is that it's the same kind of rule that adding on doesn't help. That's a biologic phenomena that when people have a low CD4 count that doesn't respond, it typically goes up slowly, but ultimately over 10 or 15 years starts to catch up. Dolutegravir is one of the now many drugs of choice in pregnant women. Weight gain, we talked about to a large extent, pun intended, and then the use of two drugs sometimes, the use of two active drugs is important in virologic failure. So let's segue over to the Q&A period. I'll just ask the questions to the panel. Just to clarify, does TAF decrease osteopenia or does TDF? Jeff, do you know?
Well, I mean, you're less likely to develop osteopenia if you start TAF versus TDF in general, particularly as you pointed out with boosted drugs.
Yeah.
Whether switching to TAF has a significant effect is debatable.
Right. How about dolutegravir? We said this, but just to reiterate, the question is about first trimester. Okay.
Yeah, again, it appears to be safe at the first trimester. That's why they changed the guideline.
And therefore, the next question is, so should it be discontinued in a pregnant woman? No.
No.
Right. All right. I've heard horror stories on bad regimens given in the ER. Well, really bad regimens.
I heard horror stories of a lot of things happening, I mean, I think, it's again, I think antiretroviral therapy requires that somebody who understands the drug starts them. You don't start somebody in the ER in chemotherapy for lung cancer, right?
Right. Which,
you don't say, here's your cisplatin and, come to clinic tomorrow, I mean.
And Paul's an oncologist, so he can.
Right. Even I wouldn't.
Yeah, I mean, I'm a big believer in rapid therapy, but honestly, I think the ER is not the place to be practicing this kind of long-term medicine. I want to do exactly what Paul says. I want to link this person. I want to get this person, hand deliver into the clinic, develop a relationship, start them on therapy. That can be done in 24 hours, 48 hours. It doesn't need to be right away.
I think that's right. I think showing people that this is important and we're paying attention. This leads to the next question: is what about the people who are ARV experienced? They show up at the ER. They hadn't taken their medicine for a while. Do you restart the regimen in the ER?
So that's, again, the biggest challenge that we have. The biggest advantage that you have is in those in programs that do HIV testing in the ER, it's actually you find the people that have fallen out of care. And retention in care and lose to continuity of care is our biggest challenge in this country. Again, you can restart them, but the most important thing is that you need to relink them. You need to actually show them a way to get back into care, because a lot of those people have fallen out of care for reasons that have to do a lot with social determinants of health. They lost their insurance, they lost this, they moved. And we need to use that opportunity to give them a helping hand and get them back into care. Less important is the drugs you give them, more important is the care you give them.
And I think, Carlos, one of the things that if we're going to routinely restart the drugs in the ER, we ought to consider having a clinic in the ER, because there's something keeping the patient from engaging in their routine care, right?
Yeah, exactly.
Especially maybe not on the first episode, but on the fourth, fifth, sixth, seventh episode.
Right, but right now the ERs are at least ours is so overwhelmed.
Yeah.
With COVID, yeah.
They'll be glad to get the patients over to our
Right.
clinic. So here's an interesting question. So if you weren't sure about how adherent a new patient is going to be, are you better off starting a PI regimen, or should you start an integrase inhibitor regimen?
The data does not support that we're better off starting a PI regimen because we're very poor at predicting adherence.
I was going to say, the data doesn't support we're good at predicting adherence.
Right. So you shouldn't be making your treatment decisions based on your best estimate of adherence. The side effects, et cetera, of the integrases are so tolerable that that's usually what, people prefer.
And you can be pretty, slack on adherence with integrase and still do fine. So
Yeah.
Yeah, I think that's right. And sometimes it's more pills or larger pills. Yeah. So,
And there may be a reason you want to use a protease inhibitor. That's
Yes.
great, but don't let it drive your decision.
Yep.
Do people gain weight with TAF due to increased appetite, or does it happen even without a change in caloric intake?
Well, it has to have caloric intake. Got it.
Yeah,
weight comes from calories. They're the same thing. So
It's a calorie booster.
yeah.
I would guess. I don't know the answer directly. I don't know that we've actually studied that. It has to be from intake, but
Right.
The type of fat you accumulate is different. And I think
the
that's
next question. So it asks that. Is it central body fat, or was it more fat all over?
You do gain some fat all over, but there's also a greater
mostly
increase in
central
the
body
central.
fat.
Yeah.
So it's not the fat redistribution we used to talk
No.
about
No.
with DDI and D14.
This is fat accumulation.
Yeah.
Everywhere. Okay. Do you recommend a regimen for 3TC, FTC resistant patient? I'll take this one because this was a question I actually had in there, and if we had to shorten up the program, I took it out. But generally speaking, if you're using, let's say you just have an M184V or M184I, the take-home point is that with an integrase inhibitor as the anchor drug, it really doesn't seem to matter that much, and the success rates are very, very similar. So I don't think that would be deterred from using the FTC or 3TC. Also, as we talked about earlier, a 0.7 log drop in viral load is generally a good thing. We saw it with fostemsavir, and you can still get that type of drop even when there's an M184V and 3TC, for example. Back in the day, Joe Aron did a study on that and saw a 0.5 to 0.7 log drop even with the resistant mutation, so quite a bit different than efavirenz and, say, K103N. Here's a question. So does it mean that we can use this TAF FTC, I had to translate it, in PrEP patients as well? So what about, well, we're going to get to PrEP in just a minute, so I might save that for Susan Buckbinder. But the answer is, yeah, you can, perhaps, but we'll talk about that. What are the issues with bictegravir in pregnancy? Do we have any data yet? I haven't seen that.
No, I haven't seen any.
I'm sure it's underway.
Yeah.
And I wouldn't use it yet for that reason, but I think as a rule of thumb, there's a few nuanced difference between dolutegravir and bictegravir. For the most part, they behave very similarly in most situations. So I would anticipate it would be okay, but we don't have those data. So I wouldn't.
I mean, you've got significant options without using it, right?
Yeah.
So why take a risk?
In a rapid start for newly diagnosed patients with viral load CD4 and resistance still pending, which non-integrase, non-TAF regimen might you use?
Well, obviously, if cost is no issue, you could use TDF, 3TC, and doravirine, until you get your resistance testing back. I mean, transmitted resistance to doravirine is still pretty unusual, right?
What about boosted darunavir?
Yep, boosted darunavir, right? TDF3TC boosted darunavir would be perfectly okay. You could use efavirenz again. I mean, there's...
But why would you not use an integrase inhibitor?
Right.
Yeah.
Okay. So would you switch a person, so coming back to our last discussion, somebody's on BIC, FTC, TAF once a day, and it's a woman, say she's 30 years old, and she gets pregnant. Do you switch her off or do you keep her on? She's now 2 months pregnant.
You have a discussion with her, right? I mean, she's got a few more weeks of her first trimester,
right,
and we don't know for a fact that bictegravir is safe, so you might switch her if she agrees.
And we probably guess it is safe.
Probably, yeah.
But without having the data,
Right.
And then
go ahead.
And then you obviously want to, I don't know how well we're doing these days in reporting to the antiretroviral registry, the pregnancy registry.
Yeah.
And they're always encouraging us all to report outcomes, right?
Yeah. And so I think the OB docs among us would switch because, as I remember our discussions going back from the very beginning, there's a real desire to really stick with what we know in pregnant women, and I think,
as long as the woman is willing,
right, and they see the outcomes on the other side in terms of any kind of adverse outcome with the birth. So I yield to them on that. Is a 2-drug regimen ideal for an elite controller?
We sort of covered this, right?
Yeah, covered that. Yeah.
I mean, theoretically, it would work.
How about this is interesting. An elite controller off of meds, are they untransmittable? They're undetectable.
Yeah, they're on.
As far as we know, yeah.
Yeah. I would answer that one by just saying it's biology, right?
Right.
And the transmission, we go back to Tom Quinn in Rakai in 2000. He published a study looking at discordant couples, and the quintile, that is the small fraction of people who had less than 1,000 copies, among those paired, one partner's infected, the other isn't. There were no transmissions in that group. So fits. I'm afraid that we've run out of time. There's only a few questions left. I'm very pleased that we got to so many of them, and I apologize if you sent one in and we didn't get to it. So I will say this before we go to our break. First off, thanks to our panel and thanks to the audience for great questions and for the engagement. We're going to be taking a 15-minute break. You can see the clock counting down there. I don't know when we're going to come back. Before we do, just a reminder that there's some pre-test, pre-course activities that we need you to fill out. It should have been done at the beginning, and then we'll get through those as the course goes on. So let's take I should play that song from Hamilton. Take a break, and then we'll come back in just a little over 15 minutes. Thanks.